meantime خلينا share.
لو أمير، سلايدات عندك جاهزة ولا تحب لسه تأخرها؟
لا لا، جاهز الأمور تمام إن شاء الله. بس وأنتوا متى مسار العدد جاهز أنا جاهز إن شاء الله.
أنا لسه مش معمول شير.
مش معمول شير؟
لا لا.
خلاص. شير. هيك شير صح؟
هيك بلش، المفروض هسه شوي بتطلع الشاشة. بس نغلب لك سيدي فول سكرين.
يس، عندي أحاول أفوت عليه من هون.
مهم.
فول سكرين.
هيك
هيك
فول
فول
سكرين.
سكرين ولا لا؟
هيك فول سكرين.
رجعت أنا كيف بدي أرجع؟ لا بدي أشوف كده. هيك ماي شيرينج.
يس سيدي، هيك الأمور تمام.
بس أنا مش شايف الشيرينج.
مش طالع عندك السلايدات؟ طيب.
لا،
ولا بأعلى الشاشة فوق عندك؟
بأعلى الشاشة فوق
هيك بالعادة بكون الشير. إذا عملت
إذا عملت إيش؟
إذا عملت نكست أو عملت يمين شمال بتتحرك معنا
لا،
سلايدات.
هي بس هي هيك صارت هيك أنا أموري تمام تمام.
إحنا تمام عندنا سيدي.
خلاص وأنا تمام. I
نجرب
think
نعمل
فول سكرين
نعمل نكست بعد إذنك نتأكد الشير.
يس.
أمور تمام سيدي.
خلاص بسم الله.
طيب احنا العدد سيدي جاهز. بتحب احنا
بسم
جاهزين
الله.
ان شاء الله.
خلاص نبلش.
ان شاء الله سيدي. احنا بداية السلام عليكم، يعطيكم العافية جميعا. نرحب فيكم بلقائنا الأسبوعي المتواصل، ونستكمل إن شاء الله موديول الأبر لمب هاند أند أبر لمب. واليوم إن شاء الله موضوعنا راح يكون سكافويد فراكتشرز مانجمنت مع الدكتور غاندي مناصير، أخصائي أول طرف علوي، مركز تأهيل ملكي. دكتور غاندي، الله يعطيك العافية سيدي.
الله يعافيك ويسلمك. الله يعطيك العافية. مساء الخير شباب، إن شاء الله ربنا إن هاي الجامعة تكون جامعة خير ونستفيد كلنا منها. يعني what we are trying to do is just giving some lectures. It is mainly oriented for the resident, but there will be different levels in this lecture. So I hope, inshallah, every point, every level of the audience will be satisfied with what we will present. Okay? So if we are going to start, Bismillah, for such as this fracture, what do we do? What to do? ليث، زيادات. What can you see? Can you describe what can you see؟ أو أي حد من الشباب بتحب تبرع. الاكس راي هاي شو حد بيشوف فيها؟ شيكات.
مساء الخير
دكتور.
سيدي.
تفضل سيدي.
سيدي، بس قبلين ابي اكس راي ادرس. I can see a proximal ball scaphoid fracture.
Yes. Can you comment more about the X-ray? About some findings other than scaphoid fracture?
other than scaphoid.
Other than the fracture, do you think this area is okay, is normal? Do you think this area is normal? Do you think this area is normal? This whitish color, Is it okay?
Yeah.
Yeah.
This
What
is
do you
an
think?
advanced case. So it's arthritis. I can
Your
see.
management plan?
According to the time of the injury itself, if it's acutely and within 2 3 months, I can go with RF.
Yeah. Do you think such
Or
as this fracture
if
can
it's
present to you with a patient of history 3 months only?
no, I think it's a prolonged time of injury.
Yeah.
So we can go with more advanced surgery like proximal therapectomy or something like that.
Yeah. Good point to start with. I'm not going to answer all of the questions at the moment, but inshallah, everybody can answer every question at the end of this lecture. So, Bismillah. We are talking today, inshallah, about epidemiology, relevant anatomy, relevant biomechanics, how we diagnose scaphoid fracture in terms of history, physical examination, radiology, classification, treatment options, complications, and dealing with complications. The best slide about the epidemiology is this slide. There is what's called rule of 70. It's not 100% accurate, but let us say that most of them, most of the sentences are okay. So 70% of the fractures in the carpal bones are to the scaphoid. It's not strange. Scaphoid is the most common bone fracture in the wrist after the distal radius. 70% of the blood supply from the dorsal branch of the radial artery, and 70% of the fractures happens in the waist of the scaphoid. 70% of the scaphoid fractures unite, and 70% of the bone covered, of the scaphoid bone covered with cartilage, and 70% of the scaphoid fracture patients are males. It's roughly 70. So males, it is 2-to-1 ratio. You can say it is 66. Waste blood supply maybe 70 to 80, but it's good rules to start with. When we are talking about anatomy, I would like always to not just to go back to the lesson number 1 in the orthopedic, but just to emphasize some point of view. Everything I will mention now, I will build on it later on in this lecture. So just let us review some few things in the anatomy. If we can go to this diagram of scaphoid, we have to notice that scaphoid is articulated proximally with the radius, distally with the trapezium and trapezoid. It's connected also with the lunate. There are some ligaments that are very important in the wrist, such as the scapholunate ligament and the lunatroquatrium. You can see here, very important structure. It is the Leicester tubercle. If you go just anterior to it, we will find scapholunate ligament. So it's not the scaphoid. Everybody can try to feel his Leicester tubercle, and we will see what's going on with its anatomical importance. Scaphoid bone is a regular twisted peanut bone. So it is twisted. It's not a regular bone, just not like a radius or femur. It is twisted. So if you need to study the bone, you have to have a 3D imagination. It is boot-shaped like bone. That's why it's called scaphos, which is a Greek name meaning boat. Or navicular bone. Also it's the navicular bone of the wrist, which is come from the word navus, which is boat in the Latin language. This is a very important slide. See in the middle diagram, the scaphoid. This is the scaphoid, how it does look in the true lateral view. But if it is a little bit on the right side, and this side, if it's a little bit pronated, look how the shape differs. And if it is also supinated in the other way, look how it differs. So we have to keep in mind that scaphoid changes not only in AP and lateral views. With every degree of rotation, there will be changing in the shape. And this is a very famous slide everybody knows about, which is the blood supply of the scaphoid. It is coming retrogradely from the distal to proximal. There are no anastomosis, unfortunately, which is a very bad thing, that if you have a fracture or disruption in the blood supply in one way, it is less likely that bone can compensate. Both of the branches are branches of the carpal from the radial artery, dorsally from the dorsal carpal branch, and volarly from palmar branch of the radial artery, superficial palmar. This is a very important structure, a slide. I will go back to it. we all know from our study to the distal radius fracture that we have a volar tilt. So the dorsal lip of the radius is extended more than the volar one. So the dorsal lip is more than the volar one. How it's make difference? Let us see. There is what's called LISA, lateral interscaphoid angle, or AP of the interscaphoid angle. What I mean, we said that the scaphoid is twisted. It's not regular. It's irregular bone. So it doesn't have a longitudinal axis. There is a kink and an angle in the lateral view and in the posterior anterior view. So if we are going to see this lateral view, this is the proximal articular surface and this is the distal articular surface, the perpendicular lines can make an angle. It varies from 24 to 30, but should be less than 35. Otherwise, what can be happen? حدا بحكي شو any volunteer? If the interscaphoid, if the LISA increase, what's going to happen? It is a humpback deformity, okay? So this is also illustration of how does the angle differ. Look to the malunion, it's more than 45 degrees in this X-ray CT scan, but here it is a little bit normal. One thing we should keep in our mind is the relation between the scaphoid and lunate. They are not parallel to each other. There is an angle between both of them, which is about 30 to 60 degrees. There is one thing I would like to attract your attention. If you just have, if I can have your attention, not the slide, look to me. If we are talking about the biomechanics of the wrist, imagine that a malonate. Imagine this is a trochotrium. Imagine this is the scaphoid. The scaphoid, it tends to go in flexion, and the lunate and the trochotrium tends to go on extension. With the presence of intact scaphoid and scapholunate and lunotrochotrium, the whole structure will be stable. The scaphoid, the lunate, the trochotrium. If there is scapholunate injury or scaphoid fracture, the scaphoid will keep flexion and the lunate will go with the trochotrium in extension. So if we go in the lateral view, they will see increase in the angle. And vice versa, if the lunotrochotrium ligament disrupted, then the lunate will go with the scaphoid, so the scapholunate angle will be less. So again, in summary, scaphoid and lunate in the lateral view have an angle about 30 to 60. If this angle increase, so the lunate, it is more extended rather than should be, and the scaphoid more flexed, this is called dorsal intercalated segment instability, which is the DC. And if the angle decreases, so the lunate become more flexed, so this is called the volar intercalated segment instability. We will come a little bit in touch with this later in this lecture. Biomechanics. You cannot talk about anything in orthopedic without mentioning the biomechanics. So scaphoid, although it is bone of the proximal rows, but actually it links the two rows. So it affects both. If any problem with the scaphoid, the both rows will be affected. Scaphoid, as I mentioned just a few seconds ago, it tends to flex. And with wrist flexion, the scaphoid go in flexion. With wrist radial deviation, scaphoid go with the flexion. So with wrist flexion, radial deviation, the scaphoid flexes. But if the wrist extended and ulnar deviation, the scaphoid will extend. And it's very important when we are trying to take an X-ray for the scaphoid, we should put it not in a flexed position, we should put it in extension. That's why we will mention that later a little bit soon. And keeping in mind that scaphoid moves with flexion, extension, radial deviation, ulnar deviation, it's a little bit difficult to immobilize with cast unless you have to extend the cast just to the metacarpopharyngeal joints. Another thing to mention about the scaphoid, as I mentioned a few minutes ago, the dorsal lip of the distal radius a little bit extends distal. So the scaphoid, when it tries to dorsiflect, there will be when there is dorsiflexion of the wrist, the scaphoid will come in contact with the distal radius. So it acts as a mechanical block, and that's why it's a fractured in full or out of stretch hand. If there is any scaphoid fracture, waist fracture, just I mentioned before, the distal pole of the scaphoid will continue to flex, but the proximal pole of the scaphoid will try to go with the lunate, and they will go in extension. So distal flex, proximal extend, there will be an angle, increased interscaphoid angle, and this is again and again humpback deformity. This is again and again. The two segments will not be in touch with each other, so the non-union will happen due to progressive compression and flexion and extension on the scaphoid. For the scaphoid fracture to happen, usually there are two mechanisms, either compression or hyperextension bending injuries. So in the compression, look to this diagram, this slide, compression will, the distal row will just do some axial loading in the proximal row. Usually the scaphoid fractures here, and usually if it is compression, the scaphoid fracture will be non-displacive fracture, but there will be risk of instability, either scapholunate or other injuries, or peronate dislocation or lunate dislocation. So with axial compression, it is a little bit non-displacive fracture, and this is how it happens. The other mechanism of injury is hyperextension injury, which is the bending forces. When we fall on outstretched hand, there will be angulation, then there will be compression dorsally and tension polary. Then with this continue forces, the dorsal side will go in extension, and the distal one will go in extension, and the proximal one will extend. So there will be a fracture. How do we diagnose scaphoid fracture? As we always say, in orthopedic, history, physical examination, very important, and radiological evaluation later. Actually, for the scaphoid fracture, it is one of the injuries that you have to have a high index of suspicion. If you don't think about it, you will not diagnose it. It is not like a hip fracture. The patient will come unable to bear weight and easy to track you by the history. No, with the scaphoid fracture, think of any patient with falling down outstretched hand, athletes on manual worker, or high energy trauma such as motor vehicle accident, young adult. If there is a swelling, if there is inability to move his hand, and of course, if there is any associated injuries. What I mean, whenever you see a distal radius fracture, just train yourself to have a look about the scaphoid. Whenever you have a peroneal dislocation, just have a look about the scaphoid. Whenever you have any injury in the wrist, just keep in mind scaphoid is one of the guys we should take care about it. Now start with the physical examination. So, as I mentioned, this Lister tubercle, just distal to it, you will find a sulcus. What is it? It is the scapholunate ligament. It is not the proximal pool of the scaphoid. The proximal pool of the scaphoid a little bit more radial. So if we want to touch, to palpate the proximal pool, just distal to the Lister tubercle and a little bit radial. Now the waist, the ulnar edge of the waist, is just distal to the distal radius, and just ulnar or just radial to the proximal pool. The distal pool has, in the lateral side, you will find it between the EPL and ECRL, between the extensor pollicis longus, which is part of the SNAF box, and extensor carpi radialis longus, which is inserted in the base of the second metacarpal. In the lateral side, where you can find the distal pool, it is in this anatomical SNAF box. So if you have SNAF box tenderness, if it's negative, maybe you have a scaphoid fracture, but maybe in the proximal pool. For proximal pool fracture has no significant SNAF box, anatomical SNAF box tenderness. Volary, this is the distal pool. It is at the long axis of the flexor carpi radialis. Now, after doing the tender just for palpation of the scaphoid, now we start with the anatomical SNAF box tenderness. If you press here, there will be pain. And what I would like always to say, indirect questions. Grab the patient hand, put your thumb in the anatomical snuff box, or your other hand in the elbow, and ask the patient, do you have any pain in your elbow? And press on the scaphoid. If he has anatomical snuff box, no, هي يعني بالعربي انت try to distract him. امسك ايده اليمين مثلا واضغط على الاناتوميكال سناف بوكس، وايدك الثانيه انت ماسك القلب، احكي له في وجع هون بكوعك فوق. اذا المريض جنوين راح يقول لك لا هون، بس اذا مش كثير اناتوميكال سناف بوكس يعني مش راح يركز معك، لانه اي مريض اي واحد نورمال you apply simple pressure على anatomical snuff box, the patient will answer yes, I do have anatomical snuff box tenderness. Other thing is scaphoid compression test or telescope test, just like this. شد الثumb والميتاكاربال وابلاي compression على السكافويد. See if there is any pain or not. And scaphoid tubercle tenderness, as we said, for the proximal pool and a little bit of the waist also. Painful resisted pronation. Ask the patient to do pronation against your resistance. If there is pain, this also a very important sign in the to detect scaphoid fracture. And this is the Watson test for scapholonate injury. Just keep it in mind. There will be pain with attempt to scaphoid shift from radial to ulnar. Now, anatomical snuff box and scaphoid tubercle test, they are 100% sensitive, but actually they are not specific. Any trauma in the wrist can elect this pain. That's why I'm asking you to try to distract the patient, because every patient has a wrist trauma. You do anatomical snuff box, you will say, okay, yes, I do have pain, but it's not always the case. That's why we added the compression test, and assumedly that there will be the specificity will reach about 74%, which is also still low. We need more examination. So we had a history, physical examination, still equivocal. What do we ask for? X-ray? What are the X-rays that we are recommended to ask? There are 6 scaphoid views. When you ask, when I used when you were in the United Kingdom, when I asked just scaphoid view, I had 6 views. I don't mention any view, just scaphoid X-ray. Scaphoid X-ray mean 6 views. PA, lateral, oblique, scaphoid view, pronated, and supinated. They think that with this at least 5 views of them, increase the specificity and sensitivity to 100%. So how can we take them? This is the PA view. Patient just lie flat in the table, no radial deviation, no ulnar deviation. So if there is a fracture here will be detected. But you know what's the problem with this view? We said that the scaphoid flexed. So imagine that the scaphoid flexed like this, and the beam comes from this side. The scaphoid tubercle will a little bit overhang or just obscure any fracture. So it's not always good in detecting some non-displaced fractures. Lateral view, just notice how they took the lateral view, not put the patient like this. There is just like something to hold the patient's hand in this position. Usually the lateral scaphoid view not effective in detecting the fractures, but detecting the displacement. So if there is a non-displaced fracture, there is a very low chance to find it in the lateral view. And there is a scaphoid view. Scaphoid view taken with a little bit ulnar deviation, and very important thing, guys, you have to have the beam a little bit 20-degree angle. Why? لأن احنا حكينا قبل شوي إنه distal radius, distal lip is more than the extended distal lead, more than the volar one. So the distal radius surface like this, tilted. So you don't have to have the X-ray perpendicular. You have to have it like this. So as usual, the X-ray, the radiology technician, he said the beam it cannot move. So this is another trick mentioned in green. Just ask the patient to put his thumb on his middle phalanges. So you will get some degree of extension, then the X-ray will be a little bit acting more perfectly for the scaphoid. What is the advantage of ulnar deviation? As we mentioned before, so when you go on ulnar deviation, the scaphoid moves from like this, if you are looking to me, scaphoid moving like this to like this. So we will extend scaphoid. Scaphoid will be more obvious, more perpendicular to the beam. There is a 45 supinated view. You take the hand a little bit supination. They believe that it's more accurate in detecting the oblique fractures. As the pronated view here, you can judge if there is a proximal pool fracture. So this table summarizes what we were talking about. So neutral APU or PA can miss tubercular fracture. If it's deviated, okay, can good for proximal pool fracture. This is the scaphoid view, which is ulnar deviated with 20-degree tube angulation. It is good for waist fracture. If it is supinated, then this is good for the tubercular fracture. If it's pronated, then for the proximal pool fracture. And the lateral view, as we mentioned, it's not for detecting the fracture, rather than to assess the deformity. And the new guidelines of the American College of Radiography to have at least 4 views instead of 6. AP or PA, let us say, scaphoid, lateral, and semi-pronated. At least they said that it is have equivocal result with 6 views. So let us say X-ray normal, and we have to find the X-ray, the fracture. We have to diagnose it. What do we do? Usually in orthopedics, if X-ray fails, then we go the CT scan. First of all, the bone scan. Bone scan is very sensitive, but unfortunately, it is low specifically. So if you have a bone isotope scan to rule out scaphoid, if there is negative uptake, then it's okay. There is no scaphoid. But if it is positive, we don't know. It's a fracture. Is it an edema? You know, with every trauma, there will be some kind of edema. So it is not a good way to diagnose a scaphoid fracture. With CT scan, the CT scan, if it needs to be taken properly, should not be taken with the long axis of the radius of the wrist or the radius. No, should be taken with the long axis of the scaphoid, which is called the scaphoid protocol. And even with that, it is not actually detecting the fracture very well. The fracture will be minimally displaced, and we know there will be the CT scan just a matter of cut. You may miss it. And sometimes if there is artery or feeding vessel, can be misdiagnosed as a fracture, which is not, or with the twisting of the scaphoid, it might be elected as a fracture and not. So very important with the CT scan. It is good for the surgical planning. I have a CT scan before go to any surgery for the scaphoid, and it's good for healing, but also to rule out any other injuries, but it's not good for diagnosis of occult fracture. MRI is the best. So MRI is you exclude if there is a scaphoid fracture, any other carpal bone fractures, any other ligamental injury, high sensitive and high specificity. And this is the MRI with, this is an occult scaphoid fracture. Definitely it was not seen in the X-ray. Okay, suppose that we have the fracture in front of us. We know that there is a fracture. Now, how can we classify it? For the scaphoid fracture, there are more than one classification. One of them is Mayo classification. It's a Mayo Clinic classification. Grade 1, type 1, just the distal articular surface. 2 for the tubercle. 3 for the distal third. 4 for the mid-waist. 5 for the proximal pole or proximal third. It is more or less descriptive. It's not good. It's more anatomical, and it was introduced in Mayo Clinic in United States. And by the way, Mayo Clinic is a name refers to 2 brothers, 2 doctors, Dr. William and Dr. Charlie William, who born 1860 and died in 1940. يعني يعزى لهم improvement في practice of medicine in the United States, and they have statue تمثالان نحاسيان بحجمهما في مايو كلينيك. Other classification, Russ classification, which is either horizontal, transverse, or vertical. More important classification, functional classification, either stable or unstable. Stable if it's not displaced, if it is undisplaced. Unstable if it's displaced. How can we consider the fracture unstable? Or if there is 1 millimeter gap, if there is intrascaphoid angle more than 35 degrees, so there is a flexion. If the scaphoid fracture associated with the perilonate injury or DC, this indirectly indicates there are some ligament injury, so the scaphoid is not connected well with the other bone, so it's not stable. If there is a vertical or oblique fracture, there will be some shearing forces, so the scaphoid will be liable to displace. So how can we treat the scaphoid fracture? Very important question. Have we diagnosed it yet? At this moment, are we sure that they are scaphoid fracture? It's not usually the case. This diagram, which is adapted by most of the United Kingdom hospitals, talking about the protocol that what we follow for the scaphoid. So you suppose that you are here in the emergency department, you took a history, physical examination, initial x-rays, you are still suspecting having scaphoid fracture, but it doesn't appear on the x-ray. So what you will do? Immobilize and review in 2 weeks. Never, ever discharge a patient from the emergency department. Please, guys, listen to this information. Never, ever discharge a patient from the emergency department without follow-up if he has radial side wrist pain. Bring him back to the fracture clinic, trauma clinic, upper limb clinic, anyone, just to review him in 2 weeks. In 2 weeks' time, if it's okay, then it's okay. You need to further up, you can discharge him later. But if it still have symptoms, this is the issue. Take another x-ray in 2 weeks. In 2 weeks' time, if there is a fracture, then act accordingly. Unstable, surgery, stable, conservative. So there is a fracture to deal with. But if in 2 weeks' time, still you have negative x-ray and still you have symptoms, the patient still have pain, still have anatomical snuff box tenderness. So either it is a strain or either there is a very occult fracture. What you will do? The protocol there is to ask for an MRI scan within 6 weeks of the injury, yani within 4 weeks from your follow-up. Within 6 weeks, if there is a fracture, then you will go to the fracture identified. Usually, if it doesn't appear till 6 weeks, usually it will be stable and conservative management. But in 6 weeks, if still there is pain and MRI negative, 2 occasions of X-ray negative, then this is definitely something related to strain. It's not a fracture. So very important to diagnose occult scaphoid fracture. Conservative. Let us say we want to treat this fracture as a scaphoid fracture. We find the scaphoid fracture, okay, and it's stable. We want to treat it. How we do treat scaphoid fracture conservatively? There are some controversies. You have to just aware about it. Whether to put what is the position for the wrist? Is it neutral, extended? Do we have to include the elbow? Do we have to include the interphalangeal joint? Do we have to include the thumb or not? How much do we need to put the patient in immobilization? A lot of talks, but there is agreement. Having the above elbow cast is not going to shorten, maybe it will shorten the union time, but it will not increase the rate of union. So if you have it below elbow, doesn't mean the patient will have non-union if you wear it for a long period of time or a good period of time. So a duration is not the position, is matter. And also the recommendation, short arm, thumb, spica, tell the interphalangeal joint, keep the interphalangeal joint free because there is no benefit from adding more stiffness to this finger. So with a little bit abduction, guys, please do not cast a hand with adduction. Otherwise, there will be contracture in the first lobe space, and this is very important for the function of the thumb. For a distal radius fracture, whatever, if you cast the patient like this, you will end up with low functional results because he will not be able to move the thumb. So this is the glass holding position. This is the position we do usually need to see the patient with scaphoid cast. So metacarpopharyngeals are free, interpharyngeal is free, thumb is abducted a little bit from the other fingers. Average time to heal, actually we do rely on physical examination and radiological follow-up. Once we see union with X-ray or CT scan, we can say that's okay. Otherwise, you may need to prolongly immobilize the patient. They said roughly it is 6 to 8 weeks for the proximal, for the distal third, 8 to 12 in the waist, and maybe up to 24 weeks in the proximal pool. Union rate is good for non-displaced fractures that are treated with cast. So the prognosis is excellent. Okay. Surgery. Before we go to surgery, they said every time and then you may lose the track. So till now, what we have talked about, some refreshment of the anatomy. We said the distal tubercle, how it's related to the scapholonate angle, how we see that distal radius limb are more dorsal. We know that the scaphoid goes in flexion. We need to treat it by physical examination, by palpation of that just distal radius to the distal tubercle, telescoping of the thumb, painful pronation, resisted pronation. If there is a pain, you have to have 6 views at least, scaphoid view. If you still have pain, bring the patient in 2 weeks. If it's still in pain with with negative X-ray, request an MRI. The scaphoid fracture can be classified as stable or non-stable. Non-stable mainly if there is a gap more than 1 centimeter, if there is interscaphoid angle increase, or if there is any associated injuries. The conservative measurement need to have a cast just to the metacarpopharyngeal joint, the interpharyngeal joint free, and of course to have it below the elbow. Okay, are we doing well till now? Okay, so next line of treatment is the surgery, and for surgery it is fixation with a screw fixation. Mainly the screw fixation is the treatment of choice for the scaphoid fracture. We have Herpert screw and many other screws according to the companies. Every company has its own name, but you have to have headless, cannulated, double compression screw. Double compression, there is a threads here, and the fracture will be in between. Here is the threads here is not as the diameter here, so there will be double compression fracture. Now, how do we approach the scaphoid fracture? Either volary or dorsally. Volary is preferable because it has the least disruption of the blood supply. We said the major blood supply comes from the dorsal aspect, so we try to be away from the dorsal aspect. And usually it's good for if our fracture is displaced and need to have reduction. While the dorsal approach is used for the addresses of the fracture in the proximal pool. So volar approach, as we can see here, the volar approach, you have scaphoid tubercle, the longitudinal axis of the scaphoid, and the FCR. We do this ligament, this incision. Make sure, do not forget that the fixation will be retrograde. So the screw from distal to proximal. Going to the capsule, we cut it in one line. We will try to preserve as much as we can from radioscaphocapitate ligament. Once we go there, expose the scaphoid, fix it retrogradely, as we said, then you have to repair the capsule because it's contains the radioscaphocapitate and longo-radiolunate ligaments, which are very important. And this is a view of X-ray of scaphoid fracture fixed retrograde. So this is a volar approach. One thing to mention about proximal pole scaphoid fracture, the fixation will be usually antegrade from proximal to distal. This is an example for proximal pole fractures. So we use them for them at this dorsal approach. The dorsal approach used for proximal ball fracture. If you have the scapholonate injury, you need to repair. If you have scaphoid distal radius, you need to repair from the dorsal aspect. You just extend your approach dorsally. The approach is a little bit more straightforward, straight line at the dorsal aspect of the wrist, just center over the wrist tubercle. I protect the superficial branch of radial nerve. Then you'll go over the third extensor compartment, APL, go down to the capsule inside it, either inverted T or longitudinal incision. You will find the scaphoid, then fix it from proximal to distal. You have to identify the scapholonate ligament origin. So it's something like this from here, then from which you can start. And do not ever forget to close the capsule in volar or dorsal aspect. This is how the fixation from dorsal approach. It is antegrade from proximal to distal. What do we do in post-op? We do usually immobilize the patient. How much do we immobilize the patient? It depends on the fracture, duration, if there is a comminution or not. Your fixation stability, are you sure or not? The location of the fracture, is it in the proximal pool, distal, waist? Does the patient have cyst when you go inside and find the cyst or not? By usually 6 to 12 weeks, and we do have to find radiological evidences of healing. Now, what are the potential complications? And here, another error with scaphoid management. That's why please try not to reach this stage. So the scaphoid may have delayed union usually in the proximal pool, or malunited, or not united at all, or there's a vascular necrosis, there will be death in the scaphoid bone, or osteoarthritis. So if we are talking one by one, the avascular necrosis, it is well known that it is most commonly where? In the proximal third. Why? We know from our classical teaching, the retrograde blood supply can be disrupted and there will be no more blood going to the proximal board. Yeah, it's okay. That's good. How can we treat it? If it is avascular necrosis alone with no symptoms, some may try to do some prolonged immobilization. Some may go for early fixation. The aim for prolonged immobilization having some fibrous nonunion, which may have the symptoms subsided, but actually revascularization is the key. You can
دكتور
see this.
العافية
تفضل.
سيدي، بس أسألك عن المانوفر for reduction of scaphoid fracture intraop.
Maneuvers of reduction scaphoid fracture. Yes. أول شيء إذا بدنا نحكي مثلا عن scaphoid fracture, which approach you are going with? Usually you are going with the volar. If there is a displaced scaphoid fracture, let us assume in the waist or in the distal third, you are going with in the volar side. Refreshment of the edges. Maybe you put 2K weirs, extend them to correct the deformity, or with the lever, small periosteum, you just try to impact or relocate the fracture. This is a volary or dorsally. So, in short words, with levers, with 2K weirs, try to joystick them, try to catch them with pointed reduction clamp in the position that you are desiring. Have I answered?
Yes, thank you, Sidi.
For the CT scan in the AVN, look at this point, heavily dense color. It's not here. It's not the nonunion problem. It is proximal to it. And this sclerosis actually is a sign of AVN. And of course, the best way to diagnose AVN is the MRI, where there will be no signal in the whole proximal pool, okay? Before mentioning the treatment of the AVN, let us talk about the non-union. Then the treatment always shares the same guidelines. If the scaphoid doesn't heal, then this is a scaphoid non-union. It is usually at least 6 months till you see, okay, till you say this is a non-union. Usually the second or third decade because high energy trauma, high level of activity. Why do we have a non-union? Either severe injury, so the fracture is displaced in the beginning, it will not heal. Proximal pool fracture, it will not heal. If there is a gap more than 1 millimeter, not here. Associated with other carpal injuries, we mentioned the DCs, if there is a perilonate dislocation, or if there is inadequate immobilization, so the cast is very loose. And very important is smoking. Smoking is proved by results that has a negative effect in the scaphoid nonunion. It is well known for every bone that delayed union or non-union has a risk factor of smoking, but more and more with the scaphoid. So if there is a scaphoid non-union for more than a week, non-union is expected more often if the scaphoid is untreated for 4 or more weeks. This is a problem when we miss a patient in the emergency department. If you discharge a patient, you will not see him before 3-4 weeks. Then it will be a little bit too late. And the signs and symptoms of pain of non-union, pain, loss of motion, and weak grip is really not a good thing to have. If the scaphoid non-union continues, it's not only one point, it will progress to more and more catastrophic issues. The whole biomechanics, which we mentioned before, it will be disrupted. The scaphoid will not act anymore as a one bone, as 2 bones. The lunate will act as Owen, scaphoid will act as Owen, so there will be osteoarthritis. It started at the radial styloid. So from the radial styloid and the scaphoid, this is stage 1. If it is progressed to the scaphoid fossa, this is stage 2. Stage 3, if you go to the capitulum, lunate articulation, and stage 4, if it is advanced in all over the wrist. Okay. Another diagram shows the stages of SNAC, just the radial styloid and scaphoid fossa. Scaphoid fossa, then if it's lunotrochotrium or of the whole wrist. This is an X-ray of the scaphoid nonunion. Look at here. This is some element of osteoarthritis here, some element here, and this X-ray, they are not the same patient. This we can see some osteoarthritis between the capitate and the proximal pole of the scaphoid. Treatment. Now, for treatment of both SNAC and AVN, you have to have 4 goals. Preserve the blood supply. We know there is a blood supply in the dorsal aspect. We try not to have another injury to the blood supply. We have to try to put bone graft in between and to fix them. We know that there was no fixation in the primary injury. And we correct the carpal instability. If it goes in flexion, humpback deformity, if there is a DC or there is VC, you try to correct them. Usually it is DC. If it happens, then you try to correct them within surgery. Otherwise, no optimal result will be detected. So what are the options for treatment of SNAC and AVN? Either non-vascularized bone graft or vascularized bone graft. We will mention the difference between them in a minute. Or a little bit, if it's advanced osteoarthritis, you will do some surgery such as styloidectomy, which is excision just part of the radial styloid, part of the distal pool, excision of the proximal fragment. You may go for proximal row carbectomy, partial or total arthrodesis. But those are the surgeries in the bottom. They are salvage procedures. So it is a point of no return. The patient will not be normal as he was used to be. So try to concentrate on the first 2 lines. So this is a famous diagram to treat a patient with AVN and non-union. So if we are talking about waist fracture, if you have a non-union and AVN, so try to go vascularized bone graft in the dorsal aspect. But if it's only a non-union without AVN, just volar approach. In the proximal one, if you have an AVN in the proximal third, you have to do vascularized bone graft in the dorsal aspect. But if there is no AVN, just put it without bone graft. Bone grafts usually in 3 categories, either inlay or interposition or vascularized. What's inlay? And just put it, يعني تحطها حط just on the top. This is, you need a stable non-union. The scaphoid is stable, no osteoarthritis, just the fracture fails to unite it in one specific point or side of the bone. You just go and put some bone graft. But if there is more and more disruption, there is the angulation, you have to open it up, put the bone graft, correct the deformity. So this is interpositional bone graft. And of course, vascularized bone graft, it is when you take a piece of bone from the distal radius with its blood supply. So if we are talking in details about inlay graft, you go to the scaphoid, expose it, remove the sclerotic edges till you can find bleeding, osseous bleeding, put corticocancellous graft, either from the iliac crest as they used to do in the past, or from the distal radius from here, either from dorsally or volary. Fix it temporarily with K-wires, or then put a screw to fix the fracture and put him in a spica. This is another diagram for the Matt and Ross classical way of putting the graft. Fernandez or interposition, you go volary, you find a humpback deformity, open it up, correct it, and put a strut. You need to have a cortical piece to correct the deformity. This is an answer about what we said about the question a few minutes ago. How do we correct it? So if you find this fracture non-union, there is a humpback deformity, and you need to address it and correct it. So the Fernandez, they measure the angle. You put the graft, you take the graft either from the distal radius or from the iliac bone, correct it, fix it temporarily with K-wires, then with screw. The vascularized bone graft, for, of course, if you have AVN, usually if you have a AVN, or if you need to do a revision, you use vascularized bone graft. The source, either from pronator quadratus, pedicle, from the volar side, or from the 1-2 intracompartmental supraretinacular artery. The name is long, but it's easy. We will see it in a minute what do you mean by that. You go to the dorsal aspect of the wrist. This is the retinaculum, above the retinaculum. So if it is supraretinaculum, between the compartment, we know that there is a second, first and second compartment. So it is between first and second compartment. So first, second, intracompartmental. Supraretinaculum, it is the arteriole above the retinaculum. You will find it there. You try to go back, chase it, and تتتبعه till you find the area where it goes inside the bone. Protect the surrounding nerve issues. Isolate the area, K-wires, holes, try to take the graft. Here is the graft taken from the distal radius with the artery with it. Then we twist it, put it in the scaphoid, and fix it. Salvage procedure. Now suppose that we fail, we can't, there are advanced osteoarthritis, neither vascularized nor non-vascularized graft can happen. So radial styloidectomy and distal pool excision, you go and take part of it. Usually if there is the osteoarthritis in SNAC 1 or 2, as we mentioned before, just here, if it is an extensive osteoarthritis, it will be with no benefit. And the other issue, they usually do this procedure with any grafting surgery. Why? To offload, to decrease the pressure on the scaphoid, so give more chance to heal. Proximal row carpectomy, it's a very common practice. When you remove the scaphoid, lunated tracheotomy, we remove them all. This is the capitate, this is trapezium, trapezoid, and and capitate and hamate. They are articulating now with the distal radius. So it is good as to buy time, not to go for immediately for the wrist fusion. So there will be some range of motion, pain-free. It is doesn't need metal. Usually there will be significant good range of motion and pain-free. Of course, if it is extensive to the proximal pole or proximal side of the capitate, then they will do maybe mid-carbon fusion or limited radio scaphoid fusion or total wrist fusion. This is total wrist fusion by Haddad. You go and remove all of the articular surfaces on both plate. This is the treatment option if there is an advanced degenerative osteoarthritis on all over the wrist. The last complication to mention is the Nonunion. How the Nonunion happens? If there is no reduction in the scaphoid, so healing without anatomical reduction. So the patient will present with what? Pain, decreased motion, and decreased grip strength. He will have this problem, these symptoms, although he has healed scaphoid. Okay? So what do we do? If it's a young patient, we can go open it up and correct it, corrective osteotomy. If it is elderly or advanced osteoarthritis, then this is only salvage procedure can help. Take home message. Scaphoid is a twisted irregular bone. Special X-ray need to be taken about. Index of suspicion, index of suspicion, index of suspicion. Physical examination, careful evaluation. If you do still have index of suspicion, do not discharge the patient. Bring him back to you or your colleague. Stable fracture with the glass holding position. We know how to put the scaphoid cast. Surgery for unstable fractures. When we do surgery, the more the proximal we are, the more the dorsal approach are advised. The more the distal the fracture is, the more the volar the approach is. If we have a nonunion and AVN, we try to do bone grafting with vascularized or without vascularized bone graft. It fails, then only salvage procedures such as arthrodesis or proximal row carboxymy. I think we are on time. I think we covered most of the topics. Thank you.
Yes, sir. It's a very comprehensive lecture. يعطيك العافية دكتور غاندي.
الله يعافيك. إذا في حد عنده question، إذا في عنده comment، إذا في عنده.
يعطيك العافية سيدي.
الله يعافيك.
في سؤال، إذا كان عندنا مريض يعني عنده stable fracture يعني لايت ويست وستيبل يعني not indication for fixation. Is there a rule for inside fixation عشان نقلل المدة إنه يكون probability period on the back?
I think the question can stable fracture, waist fracture, and is there
stable
any
fracture?
rule? Yes, there is.
Yes,
there is. Why there is? First of all, even with the scaphoid, with conservative management of scaphoid fracture, the union rate, as we mentioned, 95%. So it's not 100%. The patient you may have is a boxer, is athlete, is someone who cannot have a cast, or he cannot tolerate a cast for a reason or another, or the patient choice, I don't want casting. This is a good indication to go for surgical fixation. And then you can try percutaneous fixation. Yes, there is a rule for scaphoid fixation, even it's scalpel. Yes.
شكرا لك سيدي.
Are we done?
دكتور غاندي الله يعطيك العافية سيدي.
يعافيك سلمك.
سؤال هلا بعد الانسايتو فيكسيشن يعني قديش انسب وقت للكاستنج بوست اوب؟
حكينا بسلايدنا قبل شويه، انتهت له بوست اوبراتيفلي.
يعني انا شفت رقم 6 ديبند على السايت.
خليني اقول لك. كمل سيد سؤالك.
هلا انت الايديا اوف انسايتو فيكسيشن لواحد يونج عنده ستيبل فراكشر انه انت تو افويد لونج تايم كاستنج.
يس.
انت شو الفكره انك تعمل له انسايتو فيكسيشن وتحطه على كاست 6 ويكس؟
راح يكون 6 ويكس، مش راح يكون ممكن اقل من 6 ويكس، ممكن على 3 ويكس. اذا انت بتحكي عن patient non displaced fracture على 3 weeks you may take the cast off.
يعني أقل وقت هو 3 weeks.
Yes, keeping in mind you have to have radiological evidence.
مهم.
يعني سوي له CT scan.
طب إيش ممكن يصير إذا فكينا الكاست after 2 weeks؟
هلا احنا بنحكي عن 2 point fixation. 2 bones fixed with one metal with one screw. There will be either rotation or the bending forces will increase. So تخيل السكافويد, the proximal ball will continue to go on flexion and the proximal will go on extension. So there'll be just like the stress fracture, the dorsal aspect will not heal. That's why we do have non-union even with surgery. But just give it the time to heal, immobilize it. Once we have bone healing, even if early bone healing, then you can go.
طيب هلا في هيربرت سكروز سايزهم صغير.
Yes.
هيربرت سكروز يعني is it better to put 2 Herbert screws better than
This
1?
is a very good talk about this question. And في cadaveric study, they found in one screw larger size is better than 2 because whatever you do, it will not be as parallel as you prefer. There will be just some 2 axes, and the more you grab the page the compression forces, they found it to be better with one screw. But sometimes you have a large patient and you put the first screw and still you have a place to put another screw, put it. But if you do have the choice, 2 small or 1 big, 1 big.
1 big.
Yes.
اوكي الله يعطيك العافية، محاضرة جميلة.
الله يكرمك، خليك.
يعني question شباب، سؤال، أي سؤال شباب؟
خلاص ما we don't need to see any missed scaphoid fracture anymore ولا لا؟ طبعا انتم ما سالتوني عن الفكره انه هلا على ارض الواقع احنا عندنا بالاردن، كنت متوقع السؤال انه على اسبوعين وجاك المريض وستيل ان بين ونيجاتيف اكس راي، do we do MRI؟ we do. ارفع تليفون على الام ار اي يقول لهم ايرجنت وجيب له واحجز له ام ار اي. او طريقه تقليديه اللي كنا نسويها بنضلنا مجبسين المريض ل6 اسابيع لانه المريض ستيل ان بين، وبعد 6 اسابيع نرد نصور صوره اكس راي ثالثه. هذا this practice is يعني it's not evidence based. بس do we have the يعني احنا بالجيش اذا نوينا ان نصور مريض خلال 4 اسابيع ام ار اي بنقدر نعم. اذا رفعنا تليفون على الاشعه قلنا له في عندنا مريض ضروري يتصور 4 اسابيع اذروايز راح يفوت من نيونن بيصوروا وبس. سلامتكم.
طيب I have a question بس معلش.
تفضل.
يعني are we jump from X-ray to MRI directly؟ ما بنعمل CT scans مثلا after 2 weeks؟
No ما بنعمل على 2 weeks. بس keep in mind 2 weeks هاي ثاني مرة بياخذ اكس راي والاكس راي نيجاتيف ولسه عندك انت suspicious of fracture. شو الفراكشر اللي بده يكون موجود؟ occult fracture, very small fracture. احنا حكينا بالسي تي سكان. CT scan is not a good modality to diagnose an occult fracture. You will miss it and even there is a high false positive. CT scan is not for diagnosing occult fracture. MRI is the best. هلا ممكن انت تصور سي تي سكان وتلاقيه ماشي، بس احنا حكينا عشان ناخذ بروبر سي تي سكان الكويل لازم يكون with the long axis of the scaphoid مش the long axis of the wrist. هم بيحطوا المريض هيك وبيصوروه. يعني راح تجيك السكافويد تعرفش كيف عمرك شفت انت كيف الريست سي تي سكان؟ يعني السكافويد بتيجي هيك شكلها هيك يعني مقطعه مش
اوكي ثانك يو سير.
هذا سيدي.
يعطيك العافيه سيدي.
الله يعافيك يكرمك.
الله يسلمك سيدي. بس استفسار بسيط، بيشنت كان مثلا عنده سكافويد فراكشر ركبنا له هيربرت سكرو وبعد الهيربرت سكرو ستيل كان في نون يونيون، في رول انه مثلا نعمل ريفيجن نسحب الهيربرت سكرو نحط بون جراف بعدين نرد نثبت بهيربرت سكرو انذر 1 يعني والله لا؟
يس. هسه اول شيء عشان انذكرت كلمه هيربرت سكرو اكثر من مره، do not forget هيربرت سكرو is a generic name يعني اسم شركه معينه. If we are talking about headless screw or whatever the screw is failed, yes we mentioned انه احنا احد الانديكيشن للفاسكولارايز بون جرافت انه يكون في عندنا المريض ايش؟ المريض failed union with surgery, either no good reduction, either can not meticulous addressing of the soft tissue, either no good compression, whatever the reason is, even with the good surgery, even with the proximal femur, with the ankle fracture, there is an union even with surgery, and the scaphoid is higher, especially if the patient presented late. So, non-union with failed previous procedures, take the screw out, refresh the edges, put a vascularized bone graft, correct the deformity if there is a deformity, and fix it.
Thank you, sir.
Yes. The most common cause why they fail actually بصراحة اللي بنشوفهم بالعيادة inadequate reduction or inadequate compression. يعني ما بيكونش ما بيكون في compression كويس، وهذا سببه مرات بنكون السكافويد when it's fractured there was a cyst. Abnormal scaphoid will fracture. Normal scaphoid will have more energy to fracture. So if there is a if there is a cyst and fractured, you have to address it well in the reduction.
يعطيك العافيه سيدي.
الله يعافيك سلمك. تمام شباب؟
أي استفسار شباب؟ يبدو سيدي ما في أسئلة.
يا سيدي إن شاء الله أمور طيبة.
الله يعطيك العافية سيدي، مجهود مبارك، محاضرة رائعة جدا.
الله يكرمكم إن شاء الله.
شكرا سيدي، الله يعطيك ألف عافية.
الله يعافيك سلمك، مع السلامة شباب، شكرا لكم، شكرا
يا
لكم.
سيدي الله يسلمك، ونشوفكم الأربعاء القادم شباب، يعطيكم العافية.